You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. This episode's guest is Jonathon Feit, co-founder and CEO of Beyond Lucid Technologies, which connects mobile medical agencies like fire and EMS with the care continuum in real time. Mr. Feit talks with Kenneth Kleinberg, Pooja Babbrah, and guest co-host Ed Daniels about an under-discussed area of interoperability as it pertains to emergency medical services and getting critical information to first responders, including advanced care directives. We hope this episode provides some information and perspectives that might be new to you, and that you'll share your topic ideas with us by emailing us at podcast@pocp.com.
Hello, everyone, and welcome to The Dish on Health IT, where we break down and discuss some of Health IT's biggest news and most exciting milestones with leading industry guests. We at Point of Care Partners are Health IT consultants who work with stakeholders across the healthcare ecosystem, and we're viewed as an independent, trusted party. I'm Ken Kleinberg, practice lead for innovative technologies, and your host. My colleague and co-host, Pooja Babbrah, and I, as well as our first-time POCP guest host on the podcast, Ed Daniels, are excited to welcome our special guest, Jonathon Feit, co-founder and CEO of Beyond Lucid Technologies. The key topic we'll be discussing today, the role of interoperability in emergency medical services, including the critical needs of first responders and EMTs. But before we jump into our discussion, I'd like to have my colleagues and co-hosts to briefly introduce themselves and tell us about themselves and what excites them about our podcast. Pooja, would you please go first?
Sure. Thanks, Ken. I'm Pooja Babbrah, practice lead at Point of Care Partners. And if you've listened to our podcast before, you probably heard my voice. If this is your first time listening, nice to meet you and welcome. I'm really excited to have Jonathon here on our podcast. First of all, because he actually reached out to us and let us know that he listened to one of our podcasts. So that's always great to hear. And then also just, over the past year or so, I've been doing some work around advanced care planning, advanced care directives, and the importance of ensuring that not only are care teams following patients' wishes, but those documents are available when providers and other members of the care team need it. So I was able to learn a lot about kind of the difficulties in ensuring that, but I know our discussion today is really focused around EMS and the EMT aspect of that. And so I'm really excited to learn from Jonathon a little bit more about that piece of it. So excited about this discussion.
Thanks, Pooja. And now I'd like to introduce Ed Daniels of POCP. Ed recently rejoined the POCP team and is currently helping organize the National E-Consent and Advanced Care Planning Initiative. Ed, welcome. And could you please say a few words about yourself and your expectation on today's discussion? And I can't help but notice that you've got a fire axe in the background.
Thank you, Ken. And yes, it's a pleasure to be here. My name's Ed Daniels, and I'm a senior consultant with Point of Care Partners. And I've spent the majority of my career on healthcare interoperability, health information exchanges, and the whole topic of automated and electronic systems in healthcare. And particularly relevant to today's discussion, I also was a volunteer firefighter and fire chief for over 14 years. Plus, on top of that, I was on the board of directors for our local fire department and EMS ambulance response service. So I have some sort of firsthand field experience. So that makes me especially excited to be a part of this discussion, to talk with Jonathon and to understand the types of new technology that he and his company are bringing to the whole world of EMS and emergency services. So, Jonathon, thank you so much for being here. And Ken and Pooja, thank you for inviting me to be a part of this talk today.
Okay, great. Now let's greet our guest, Jonathon Feit, CEO of Beyond Lucid Technologies. Welcome to The Dish on Health IT. To start, could you please tell us a bit about yourself? And for those who are not familiar, tell us about Beyond Lucid and what you do.
Yeah, so thank you very much. So as Pooja mentioned, first-time caller, long-time listener. So it's a lost art of being able to start a conversation that way, right? So, to pick up where Ed left off, actually, so I am not a field practitioner. Wish I was, and actually we're coming ironically up to the 20th anniversary of September 11th, which is also the day that I joined the military. So I enlisted on September 11th. My military occupational specialty was to be a field medic. So actually it's kind of what got me into this always straightforward, never complex industry. But I have Tourette syndrome. So if any of you seem like if part of the screen looks a little twitchy and fuzzy, it's not you, it's me, I promise. So, it turns out that neurological dysfunction and the United States military don't get along very well together. So I was not long for that life, but wanted another way to serve. And being not a practitioner, but a technologist seems to have been that focus. I spend, and Beyond Lucid Technologies as a company, we spend about half of our day in the world of fire and mobile medicine, which encompasses fire and EMS and non-emergency interfacility transport and a variety of other things, critical care, both ground and air. So there's a lot of different layers to that, which is part of the complexity of this industry that I think the lay person doesn't understand, but hopefully will and should and can. Like if I can learn it, anybody can learn it. I didn't come from this industry. I don't have a family member who's a firefighter or a police officer or whatever. I came into it to solve some problems. The other half of our day is in the world of electronic health records and interoperability, health information exchange, patient matching. One of the ironic things, as Pooja, you mentioned about the advanced directives and whatnot, our company is really honored, and we're doing some cool stuff that I can tell you about if you'd like, but we are honored to run the Oregon Pulsed Registry from a technology perspective. It's the portable orders for life-sustaining treatment. They go by different names in different places, but it's essentially this end-of-life order and representing the patient's wishes. And now we're actually branching into focusing on pediatric special health needs, medical complexity. And to be honest, as a technologist, I actually find registries a bit boring. They're a database. It's not particularly complicated. There's a lot of things that go on in it, but at the end of the day, it's a database. It sits in the background. What got us into this space is identifying, as Ed referenced, what the field provider does and needs to have right now. Particularly when you look at things like end-of-life medical orders, you get a margin of error of precisely 0%. Because if you get it wrong, people either die or they don't die and wish they had died. I mean, that's kind of a crass way of putting it. But at the end of the day, the patient's medical wishes either get followed or they don't. And so there's an extremely narrow margin of error. And those are the types of problems I like to engage. When I got introduced to this topic of these registries, because I found out from my field provider friends and others they work with that they didn't have access to those pieces of information, right? How are you supposed to do your job to represent the patient's wishes and make sure you're following them if you don't have any way to know them? And so that is a very sticky and interesting problem. That is what we do. So Beyond Lucid Technologies is a company focused on interoperability and mission critical context, whether that is the patient record as it's captured in the field, making sure we can enable it to be captured in the field and move to the hospital fast enough that it can be useful, right? So it doesn't just show up as a legal record 3 days later. It shows up as a clinical record 30 seconds later. So you can use that for triage. You can use that to identify syndromic surveillance. The state of New York is working on this as we speak. It's only taken a couple years, but they are now looking at having documentation done within 4 hours so that you can see real-time sparks of infection for things like COVID-19. Changes the whole conversation when you start to talk about real-time interoperability, not just can I get it there eventually. End-of-life wishes. Again, the pediatric special health needs. The future of our company focuses a lot on car crashes. We actually won a patent this past year on a system and method for post-vehicle crash intelligence. For the first time, I'm sure everyone, a lot of people listening to this conversation will be familiar with OnStar. Great service. Provides information about location, airbag, and velocity of impact in newer cars. Absolutely nothing about the people who are impacted by the crash. And so if the responders are going to arrive on scene, we call that halcyon post-crash intelligence. If they're arriving on scene, couldn't it be neat if I could know how many people might be in that car, or if any of them might be a hemophiliac, or have a past history of stroke or heart attack, which may affect care, if anyone's a child, a special health need, or has a pulse. So they all kind of come together. And so that focus on these mission critical movement of data. And by the way, one piece of it which got me to reach out to you guys, Pooja, of course, was about the social determinants of health. The other context of these patients, patients as people, is a very important aspect of interoperability and a lot of the conversations around things like Commonwealth and care quality and these interchange efforts, right? You may be a patient in many places, but you may be a patient in many places, you're a person only once, right? And so understanding what your context is, because even if you don't have an organized program around engaging those realities, they are nevertheless the patient's realities, right? And so understanding if you can't document whether somebody is homeless or food insecure or has a phobia or something like that, then how can you provide the right care? And so we looked at that from a 911 perspective, but also the whole gamut, and basically said, it's great if hospitals have it, if clinics have this information, but if the folks going to the patients in moments of crisis don't have access to it, game's over.
Jonathan, let me stop you there, because you're diving into a lot of the great topics that I'm hoping we're going to get to here in this podcast. And I have to say, just from the highest level, this topic of EMS, we don't really hear a lot about it in health IT circles. Right. And there's some technical aspects of this. You mentioned fire and Commonwealth and so forth. We'll have a chance to get into that. But first, EMS, as I understand it, historically has been billed and reimbursed separately from other healthcare services, viewed as transport, EMT and paramedics as ambulance drivers. Is that still the case?
Yeah, sort of. It's got a bit of an asterisk because it's evolving due to the pandemic. So there's a fellow named Matt Zavatsky, who's a very well-known figure, a very influential figure in EMS. And he actually is the one who taught me this. I'd been in the business probably about eight years already before I realized where the problem sits. And it kind of stems, as many things do, up to the federal government. We can have a whole conversation around the federal and various levels of oversight of EMS, but it really comes down to this. CMS, up until basically the last 18 months, has categorized EMS as a supplier to healthcare, not a provider of it. And that's a really, really important distinction, because it's changed, like you said, it impacts not only the way they bill, but actually the laws pertaining to interoperability as well. So things like meaningful use do not apply to EMS. And that's a really, really big problem, right? So we have a different data set. It falls under the Department of Transportation, not the Department of Health and Human Services. Related to the types of data that get captured. The simplest way, Ken, of thinking about EMS bills for service in the United States is the most expensive taxi ride you'll ever take. In fact, there is only one, with the exception of the emerging ET3 program at the federal level, which is looking at a value-based care experiment, basically. EMS, mobile medicine in general, bills on a per mile rate that is cost adjusted for the certification level of the provider and the severity level of the patient, and that's it. And so it's kind of the grossest version of a capitated cost structure, because everything that you do in the field, whether you're giving meds or you're doing EKG monitoring or whatever it is, or putting on a splint, all of that has to go into that per mile rate. And it causes enormous challenges in terms of, again, in some folks' case, folks being able to keep the lights on. So, EMS emerging as a central part of not only safety net care, which is an enormous part of, EMS is the primary provider of choice for huge portions of the United States, whether they like it or not. You go into rural spaces, you don't have a whole lot of docs. So who do they call? They call 911, right? And there's been a lot of hay made, much deserved over the last year, about the impact of that on rural services and their inability to literally keep operating. And if they can't, who's going to take care of those people? So that's a huge part of it. But the other bit is that it's a 24/7 job. Right. And so, there was a story a long time ago, kind of an ad campaign that never really came to fruition around what would happen if you called 911 and no one picked up. And that's really it. Right. If you are a bedridden patient, homebound, if you need dialysis and you can't drive, who's going to get you where you need to go? And if you don't go and then you decline, who's going to come and pick you up off the floor or off the couch? It's the same people. So viewing them as a provider is a critical distinction. And something that thankfully is starting to emerge in the shadow of the pandemic.
Thank you. All right, let's bring Ed into the conversation. Ed, what are your thoughts about some of these points about how EMS is reimbursed?
Well, I think that what Jonathan's saying is correct, that historically they used to run ambulances out of a furniture store and an old Cadillac station wagon. And the idea was to get a patient out of whatever situation they were in as fast as possible and to the hospital as fast as possible. That whole paradigm has completely changed. And the idea is to provide the level of care that's needed, whether, as Jonathan said, it's picking up the patient off the floor or performing life-sustaining CPR. That's what the people do that arrive there, and it's definitely a provider type of situation. So I totally agree with Jonathan's observation that it's time for a change in how this type of care is being provided, perceived, and paid for.
Yeah, I think about the transition from fee-for-service to value-based care, and I want to bring Pooja in here to talk about this. I can imagine in the hospital charging for how far you push the patient in the wheelchair. I don't see that making a lot of sense. So, Pooja, you've seen how healthcare are bringing pharmacists into the care team. Same here for EMS and paramedics?
Yeah, it's, I think the thing we need to be thinking about, actually just this morning, I was reading the blog post put out by the new CMS administrator, Chiquita Brooks-LaSure, and, some of her colleagues in it, they're talking about the progress that they've seen at the CMMI Innovation Center, which was essentially, it was enabled through the Affordable Care Act, and it was all focused on these value-based payment models. And what they were saying is they've looked back over the past 10 years to see what's been successful. And essentially the models that have been successful have been very few, let's say that. But there have been a handful that have been successful that have actually, basically it's because they're being mandated and not voluntary. So I think there's a couple things to be thinking about around this. One is how do you bring these emergency services folks in as actual providers, and getting them reimbursed under some of these models is going to be really important. And Ken, to your point, right, we've talked about this on other podcasts where, the whole model of paying pharmacists needs to change. Well, that's the same situation we're seeing here. They should be part of the care team, right? Just like pharmacists are, just like others are, but then you've got to change that reimbursement model. So I do think that there's going to be some focus on this, hopefully, now that we're starting to see some of these new models potentially coming into place, but it's absolutely needed, I think, as folks like that being part of the care team and getting reimbursed under some of these value-based models.
And just to add the whole idea of being paid for transporting how many miles you go, well, in a lot of cases, you might actually want to care for the patient at home and not transport them. That's directly contraindicated by the way that they're reimbursed at the moment.
And I think that's where I hope, and obviously with apologies for the fact that I talk too much, I'm apparently a little passionate about these topics, but there is an allergy in the mobile medical arena to good data. And I think this is something that, especially Pooja, when you mentioned folks like CMS, who are not only extremely wonky geeks, working there, and I don't think a lot of people, by the way, understand just how good they are at their job. They're really, really good, dedicated people working at CMS and CMMI and throughout federal government and state and local government too. But they need fuel to work with, right? And they need to be able to process something. And so for a variety of reasons that really kind of come down to how people explain mandate versus voluntary and mandatory, as you mentioned, right? I think that's really a great way of looking at it, right? The importance of capturing not only data, but good data and being able to contextualize it is the fuel that they need in order to be able to see what's working and what's not. Mobile medicine in general has an allergy to good data. Some of it goes down to who takes these jobs, right? Running on the truck. And most folks don't go into mobile medicine because they want to be statisticians or because they like typing and writing. That's just not that kind of job, right? So the idea that I need to put in my information and take the time to do it properly, this is by no means an EMS issue. The same thing is happening in hospitals. Why some places have scribes, right? And we know that this is a trend. But the problem is EMS has so much catching up to do that they just don't, there is a lack of understanding around how much progress can be made. If only you would give those folks who need data to create actuarial tables, who need to be able to understand the cost inputs, as Ed's talking about, right? If you don't have anything to measure, you're not going to be able to change anything. And so I think that is something that we, and again, it's why I reached out to you guys as I did, because you're talking on such a level historically about how to make this stuff matter. And I feel like when nurses talk to nurses and docs talk to docs and EMS talk to EMS and fire talks to EMS, fire and so on, right? They don't hear from outside. And I think to get the perspective, the breadth of perspective that you guys and your colleagues have could go a huge distance or I would say, as I correct my kid on that, it could go a very long distance, not a huge distance, just a long distance, right, toward helping close the gaps in understanding that allow the different parts of the ecosystem to talk to one. Because there's a lot of folks who don't realize these problems exist in pharmacy. They exist in walkabout hospitals too, right? I mean, no one wants to sit and type into an EHR. It's not magical. The information needs to get there somehow. So I think we need to do some truth telling and explain to folks just how real and important it is to get the data in. And then from a design perspective, as software companies, we need to make it easier. And we need to make it more conducive.
Right. So Jonathan, we're definitely now into the topic of interoperability. But I have to ask, in the case of EMS, don't they use their own pre-hospital care record system? I thought I read that it was called NEMSIS, NEMSIS. Maybe I'm not pronouncing it right.
That's
and
right.
It's kept at state and national levels. Could you tell us more about this? And does it connect to EHR systems at hospitals, for example?
So it can, and it is. And so, show of hands, how many of you guys have seen the movie Contact? Same question to the audience, right? Jodie Foster, remember? What first rule of government contracting? Why build one when you can have two at twice the price? Right? That's basically what you end up with here. So NEMSIS is a separate and therefore unequal data set. It is maintained through the National Highway Traffic Safety Administration, and it has a fairly rich history of sort of focusing on car crashes and cardiac arrests that led to car crashes. And it's a gross simplification, but it is the EMS data set at the national level. It filters down through the states, and due to what I think is a pretty serious set of problems, and I'm happy to say this on record, by the way, there has not been sufficient explanation at the state, county, regional, or local level as to why it matters. And what you just described, Ken, is why it matters. There is a mechanism by which to convert one into the other. And in fact, since we're talking about value-based care, I'm going to lay it out for you guys here. My company actually got funded by the California Healthcare Foundation in 2015 to build the bridge and create it was the first of its kind. It's still the only real-time version of a conversion engine for EMS data to HL7. Continuity of care documents is our preference, but it's an HL7 output. And what was interesting and really quite fascinating is that we did a gap analysis. We worked with folks like Kaiser Permanente and American Medical Response here in California who had advocated for interoperability and wanted to get it done. And we did a gap analysis to understand what it would take to go from one to the other. What we found, I estimate to be about an 85% overlap between the EMS data set as required now and for the last several years since 2013 and the HL7 CCD. So that 85%, well, what's the difference, right? What's that 15%? Because that's everything. And so what I found was that the spaces to be filled in fell largely into three buckets. And you're going to like this. They were family history, past encounters, and mental health. Family history, past encounters, and mental health. And for the non-EMS folks on this call, doesn't that sound a lot like social determinants, right?
Yeah.
And in the EMS world, we call that community paramedicine or mobile integrated health. Right. And now at the federal level, it's been blessed through a pilot program through CMS. And Pooja, you mentioned CMMI, it's where it came from, which is the ET3 program. So this emergency, essentially non-transport based care program that's looking to be measured in a couple hundred locations across the country. And the idea is to fill this gap, right? Because in a 911 encounter, it doesn't matter whether your parent has diabetes. It only matters whether you have diabetes, right? Do you have a blood sugar problem? But if you're going to see a person over time and watch them longitudinally, see if they get better or get worse and be measured and paid accordingly, right? It absolutely matters whether you have history and risk factors, right? And if you're homeless and not homeless, or if your food insecurity or loneliness is leading to other healthcare deterioration, right? That just started. So this program was slated to go live in 2020. It got pushed back to January 1st because of the COVID, but it is emerging. It is right now, and it is plugging that hole. So yes, that hole can be plugged. In fact, my organization's been doing it for about 6 years. We've got about 300 hospitals on our network today that can each receive EMS data in real time from EMS. And Ed, you're in Colorado, right? So not to put too fine a point on it, but the Larkspur Fire Protection District in southern Denver does not take the bow or get the credit it deserves. It was the first fire-based EMS program in the United States to send real-time EMS data to Centura Health in 2017. 2018. I believe it was January 2018. That's a coup. I mean, that was a huge thing. And it's a small service, innovative service, and it showed that it was possible. And so, yes, Ken, it's definitely possible. But again, the details matter, and a lot of places don't. A lot of agencies and their hospital partners, quite frankly, don't understand how to speak to one another, to say, this is what we need. And if you give us data in this format and this timing with these verifications, we can suck it in. But Epic and Cerner and Meditech and Athena, they have been extremely forward in terms of saying, give us the data, meet the standards, and we know what to do with it. And then EMS sort of says, how is that nemesis?
You mentioned earlier that you were, you mentioned Commonwealth, and I understand that you were one of the first, if not the first EMS company to join. And I'm curious about that, as well as, are you getting some of this SDOH data from HIEs?
So we put landing points in the record systems to be able to do that. So yes, and one of the things that we addressed, let me do those backwards. So about 2 years ago, again, pandemic kind of changed some things, right? But about 2 years ago at the National Association of State EMS Officials, there was an outcry for social determinants and contextual data, which, as you guys know, has been largely local, right? So community-specific development of data points. And people started to say, how will we affect interoperability even within mobile medicine if we don't have our arms wrapped around that, right? So folks basically said, will anybody raise their hand and be the technology company that does that and develops a superset? I did, and I was quite blunt about it at the time, and we've done it. And we actually have an announcement that I'll give you a preview of. It'll come out probably in September, that we have now, as of about a month ago, for the first time ever, enabled SDOH data to be populated into any 911 chart. So now, because you can go roll on a patient who's homeless or has any of the other contributing factors, adverse childhood experiences, et cetera. And the fact that you don't have an organized value-based care program doesn't mean that those people aren't being affected by it, right? So we populate that now into a 911 chart, and you can track that historically. So that was something, again, we just introduced it. It's from one of our community health worker programs that asked for it. And it was a light bulb going off that why keep this in a separate data set when it should be integrated? So that's one. The Commonwealth angle, Ken, was very, very important to us. So we joined that in 2015, right before we got this funding from CHCF. And we actually backed away from it. So I learned an enormous amount from the folks at Commonwealth. I have nothing but love for them and the folks at Care Quality too. Things like strong ID, right, are hugely important to patient matching. And if you're going to look up someone's end of life order, you better make sure you're looking up the right person. A couple of us on this call have many ways of spelling our name, right? Certainly my name, you spell my name with an A-N at the end instead of Owen, and you find a lawyer in North Carolina. I learned that during my online dating days. People thought I was lying. Learn how to spell my name. So if you can't get that right, again, game's over, and you could end up causing serious harm. The problem was those requirements, both Care Quality and Commonwealth for many years, required an affirmative permission from the patient to say, I authorize you to look me up. Can't do that in the back of an ambulance necessarily, right? So if the patient's unconscious or they're in altered mental status, or they've been involved in a car crash, or they're on drugs, right? For all those reasons, if you can't get permission, you can't look them up. You can't trust what they tell you. And all of this is about trust framework, right? The trust framework is critical to everything we're talking about with interoperability. And EMS has a serious problem with dirty data. So we backed away from it because break glass is not enough. It's not just to have permission. You have to have confidence in what you're putting in and what you're getting out. Now that's changing. So as of the ONC meeting 2020, right before the world shut down, we learned not only that FHIR version 4 had been balloted and approved, but that awarding of the trust framework contract to Care Quality Sequoia Project, that provided sort of a national language to start to talk about this. And so I'm a huge fan. I think it's long overdue. I wish folks had engaged EMS earlier. But, like September 11th, right, 20 years ago, the spotlight is on this industry now. Only it's instead of it being for a day, it's been for 18 months. And so now that conversation is emerging, and we're pretty excited over it.
All right. So we've talked a bit about social determinants of health, and related to that, consent. We're mentioning now advanced directives. Pooja and Ed, these are topics that Point of Care Partners looks at a lot. Pooja, maybe you could start with how you see EMS and how they might use SDOH and or consent advanced directives. I'm sure, Ed, you'll have something to add here as well.
Yeah, so I think it's great, Jonathan, to hear what you guys are going to be announcing, because, when I think about it, who are the people that are going to know some of the things, right? Or is this patient homeless? Or do they have food available? Things like that. It's like those frontline people that need to capture that information. So, we've talked before about the Gravity Project and what they're doing, the new version of USCDI version 2, right? There's specific data elements that are now going to be part of that. Of course, it's not named yet, and it has to be, interchangeable, but that's where we're going. going. And I think so much to unpack, and it's exciting to hear what you guys are focused on. And I guess one thing that I was thinking about as you were talking about, the fact that you have, because it's been under more of the kind of the transportation arm, right? It reminds me a lot of PDMPs, right? Because they started as the enforcement agencies and the law enforcement agencies within states. Now we're bringing it more to the public health side of saying, exactly, okay, we need to be tracking, right? And I feel like some of this is kind of tying into that. And I'm hoping with companies like yours that are now, that are connecting to care equality, that are focused on social determinants health, just trying to make sure that, we're saying, okay, we know not all of this data is going to be interchangeable, but, can we wrap some of the mobile systems that you guys are focused on, use some of that USCDI data elements to be able to, to share that information, right? That connection you mentioned in Colorado about, sharing that information with the hospital. It's those pieces of data that need to go. But then, I'm going to leave it and let Ed talk about this piece, but it's the consent piece, right? Like, how do you get that informed in consent prior to someone being in that situation?
Well, I think it's just really exciting because it just happened about 2-3 weeks ago. But as you talk about the PDMPs and sort of tying in with things, the Oregon Center for Children and Youth with Special Health Needs, which we're honored to serve in helping build the first in the United States statewide registry of medically complex children and this special health needs. They won some funding, federal funding, tied specifically to now tying in that conversation with police and the local dispatching system. So, the PDMP sort of going the other way, right? Looking at policing bleeding into healthcare. This is going the other direction. And the realization was that, let's say you have a 16-year-old, with a mental or behavioral deficiency, a dysfunction of some kind, maybe they can't follow instructions, right? The responders who are often first on scene are police, right? And so if you don't know that this happened here in California, not too far from my home, where there's an autistic teenager who had a very unfortunate run-in with the police because he could not follow instructions, right? And then we also realized shortly after engaging that conversation around special health needs in children, those kids grow up, right? Sometimes you're a 25-year-old or a 35-year-old child, right? So you may still be intellectually 9, but you have the body of an adult. And if we don't engage those other resources that are not traditional healthcare, but often first responders on scene, not only can you have a problem in interoperability and care, but you can actually have an unfortunate event that you can't so easily pull back from. And so Oregon and Oregon Health Sciences University plowed through that barrier, and they just got funding. So there seems to be a recognition that those social determinants go well beyond health. Sometimes they are matters of life and death, and they're starting to be recognized and incorporated into that data set. So that's going to be the next year's worth of work that we do in Oregon. So I'm very, very glad you mentioned the one direction. We're going the other way and meeting them.
I think you're exactly right about that. We don't have time for a lot of war stories, but just to give an example, the work that I did, fire and EMS, was primarily in a more rural type community. There you have some kind of basis of information for who has behavioral health problems, who has problems with proper nutrition, age, family circumstances, et cetera. So the social determinants of health in a lot of ways in these smaller communities are known by the volunteers who are actually responding to these calls. But a number of years later, after I retired from the fire service, I had the opportunity to go on a call with a really unique organization in Colorado Springs, Colorado, which was a 911 unit that had a police officer, a paramedic, a behavioral health social worker, and we responded to some calls on homeless people. We ended up accessing not only the justice system, legal history for this one particular homeless person, but also the local HIE. We reached out. We had to call the office and have them look up on the HIE database the history. But Jonathan, you mentioned the encounter history. That ended up being extremely important here, determining whether to transport this person to the emergency department or jail. Those were the two choices. So we took her to the emergency department in this case.
And quite possibly saved a life. Good for you.
And on the consent front, anything you'd like to add here about the challenges here in advanced directives?
It's and Ken's referring to this project that, and as Ken introduced me, I'm working on now related to electronic informed consent and advanced directives. I've got a bunch of war stories on that too, but I'm not going to go into them right here. We just don't have the time. But getting consent from the patient in advance is always the preferred mechanism. And sometimes when you're on scene, you have a chance to ask the patient for consent, assuming that they're competent and responsive, able to give you an answer. But it is certainly a problem for patients where, they're not able to respond or clearly not in a situation where they can respond. And part of this depends on the state that you're in, whether you can break the glass and get access to records or not. So it's a very complicated question, and unfortunately, not one answer across the whole U.S.
Right.
As we work towards wrapping up this packed podcast, Jonathon, it's our tradition to ask if there's anything else that you would like to add or actions you'd like to see the industry and our listeners take, perhaps something to do with the pandemic and vaccinations?
Yeah, thank you. And I know this is a big and controversial topic for a lot of people, so I'm going to be clear that I'm not talking about vaccinations per se at all. But I do think that truth-telling is important. And I think when we're going to talk about things like interoperability and what is possible and what's not in the now versus the could be, I think it's important we start hearing words like mandates, that it's very important for folks to understand that data quality is really kind of where it starts and ends. Right. So I was a journalist for the first half of my career. I wrote my first investigative piece in probably almost a decade earlier in 2021, where I did an expose essentially on why for almost the past decade, the federal government has been aware that state registries of vaccination, immunization registries couldn't talk to one another. And sometimes even inside states, they can't talk to one another. I mean, we talk about pharmacy and EMS and so on. IIS is a pretty huge part of this process right now. So to the degree that whether you're in California and move, or if you're in Dallas and go to Houston, which I did in my own podcast, I'll put in a plug for, it's called Sacred Cows and Data Cubes through the Journal of EMS, if anyone wants to see it. But it's a two-part podcast, almost 3 hours, talking with field practitioners about how they can and can't access data for their own folks, even their own personnel, right, in the state registry. So I think it's really important to understand that the details matter. And if you're going to hold somebody to account for whether or not they get a vaccine, for example, shouldn't you have a source of truth? Right. And that's lacking in this country. So for all of the discussions around whether vaccines are good, and I have mine, I certainly would not tell anybody not to. But I think the question of can you prove it is a very different conversation. Right. If you're going to require somebody Ed's talking about folks who are, not necessarily able to speak for themselves. Right. If you're an 80-year-old bedridden person with pre-existing health conditions and other social determinants that have gotten you to that point, and you have to remember where you kept the little card because that's the only evidence you have, which, by the way, looks just like a jury summons card. It's literally the same size, right? At least in California. That's a problem, right? Do we have evidence? And so if you're going to hold people to account, or if you're going to have EMS data talk to EHR data, the details matter. And so I really hope we start having a conversation, this would be my last point, Ken, that goes beyond the bumper sticker. It goes beyond a Twitter feed, right? It's really about how can we do this? Because if we don't do that, we're going to find ourselves in the next pandemic having not moved the ball at all, right? We'll say we identified the problems, but then we moved on to the next thing. And I think if we can shine enough bright light on the need to get smart people in a room and hash out the details, then we can really make an impact so that we're more ready the next time, and we can no longer say we didn't know that this was coming.
All right.
How's that for
Pooja, I'll give you the last word. 30 seconds.
30 seconds. This has been great. I just feel like we just skimmed the surface. There's so much to unpack here. And, I'm just excited that we were able to bring some light to this topic. But going back to this whole idea of the registry and the immunization, all that is funny because, I'm on the NCPDP board of trustees, and we're actually talking about this exact same thing, right? That we need this kind of facilitator model of saying there's this data out there, there's standards that are in place today that we could be capturing data, right? And not whether doesn't matter what state you're in. So why aren't we looking at standards that are in place using some kind of central, and I hate to use the word database, right? But some kind of central repository, that you can just tap into, and that's what's needed. So lots to unpack. I know we talked about a lot of things, but excited that we're bringing now kind of this EMS responders into the conversation too, because to me they're just another piece of that care team that we need to be talking about in all these different topics. So
okay, great. I want to thank my co-host Pooja Babbrah and our POCP guest Ed Daniels, and especially to thank our special guest Jonathon Feit, co-founder and CEO of Beyond Lucid Technologies. And thanks to our audience for listening to this edition of Point of Care Partners, The Dish on Health IT. Please follow us on Apple Podcasts, Spotify, or whatever platform you use to pick up your podcasts, including our most recent platforms, Healthcare Now Radio and the podcast channel. And if you prefer, you could also watch extended versions of our podcast on the POCP video channel on our website. Now, the summer may be coming to a close, but please remember, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with fire accelerators? Email us at interopoutlook@pocp.com to learn more about our new Interoperability Outlook subscription monitoring service.